Good afternoon, everyone. Welcome to the American Enterprise Institute. I'm Tom Miller. Our event this afternoon, Better Hospital Price Transparency, a conversation with Florida Governor Rick Scott. As you know, hospital prices are a little bit of a guessing game on occasion. They can vary widely among different payers, within market areas, even across them, and across service categories. Sometimes it can be rather hard to know exactly what the price of things are until you see one of those complex hospital bills. Knowing in advance is a little more of a difficult straddle, often unrelated even to the quality of care in terms of what the list price seems to be. Patients who are uninsured, those who are covered under high-deductible plans or in narrow networks receiving out-of-network care are particularly vulnerable to finding out that what they're billed for could be a much higher price than what they expected. Governor Rick Scott of Florida has quite a lot of thoughts on the subject. This is an issue that's come up in other states as well. How to make a little more sense out of hospital pricing, make it more consumer-friendly and transparent, and provide some consumer protection safeguards along the way. Governor Scott is in his second term as governor of Florida, first elected in 2010. Like many of us, he got a law degree but found better things to do later on. And among those, after practicing law for a period of time in Dallas, primarily representing companies in the healthcare, oil and gas, and communication industries, he got involved in healthcare, making an offer to purchase HCA Incorporated, but that offer was rejected, so he proceeded to start up his own operation, Columbia Hospital Corporation, with he and his wife's life savings at the time, and soon started also another organization called Conservatives for Patients' Rights, which advocated for free market principles of choice, competition, accountability, and personal responsibility in healthcare. Now, Columbia was quite successful. When Governor Scott left that firm in 1997, it had grown to become the world's largest healthcare company. Tons of employees across 37 states, and making it the seventh largest U.S. employer at the time and the 12th largest employer worldwide. But he has many other thoughts in terms of public policy. He's, as governor of Florida, worked to revive its economy, and now is working to revive what might be a more consumer-friendly healthcare environment. Please welcome Governor Rick Scott.
Thanks, Tom. Well, thanks for the opportunity to be here. First off, how many of you from Florida? Anybody from Florida? How many of you gone on vacation to Florida in the last 12 months? You pay 24% of our sales tax. So our government is funded by sales tax and property taxes, and so if you come there as a tourist, I want to thank you because you help us keep our taxes low. If you have a friend that buys a home or you buy a home and don't use it, you pay our property taxes, so thank you for that also because you don't use it, don't require any services. We've had a big turnaround in our state in the last 5 years. We've added 1,025,000 jobs. We're beating Texas. We're beating the country in job creation. Our job growth rate is up 3.5% in the last 12 months, and the national number is 2.1%. I have basically 3 jobs. Is one, try to make sure people can get a job, make sure people can get a great education, and make sure people stay safe. But part of that job is to try to make sure things are fair and people can understand pricing. Keep the cost of things as low as you can in the state, whether that's utility cost or healthcare cost, whatever it is. So there's no reason, in my opinion, that we should know what things cost. How many of you have purchased a piece of clothing or gone to a grocery store or gone to the movies or gone anywhere and said, whatever you want to charge me, have at it? We don't do it. And if we don't do it, I mean, the prices are going to continue to get exorbitant and people are going to be taken advantage of. So let me just give you some stories. And these are all stories that people have told me directly themselves. Mom took her son in for a broken arm into a hospital, had a cast and a temporary cast and x-ray, $3,569. Individual went in with anxiety attack, a breathing issue. Went to an ER, $5,300. Another individual went into a hospital for surgery. The hospital knew exactly what insurance they had and gave that patient an out-of-network doctor as a hospitalist. So the cost would be, not that it was intentional, but the cost for that patient was way higher because of co-payments. 2-night stay in a hospital for a urinary tract infection, $38,000. $38,000. Cut on a thumb, no stitches, $2,000. Broken ankle, all was done was x-ray and temporary cast, $5,000. 4 days in a hospital for high blood pressure, all I had done was lab test, radiology test, and CT scan, $78,000. Chest pains, $2,300. Urinary tract infection, $20,000. A patient went to a hospital, had a little bit of bleeding after surgery at another location, gone back, I guess, the day after, and just wanted somebody to check it. Nobody was in the waiting room. Person came out, did the blood pressure. He kept waiting for an hour. Nobody took care of him, so he left. No service other than the blood pressure test in the waiting area, $835. Patient goes to a primary care doctor and is worried about carpal tunnel. Goes to a neurologist, is referred to a neurologist. The doctor said your fee will probably be $2,500, $2,800. Now, in every one of those instances, I asked the patient, do you believe you've been price gouged? And every one of them said yes. It doesn't make any sense that the hospitals can't tell us their prices. So what I've pushed this year is that all hospitals would post all their prices on their website. On top of that, when you go in for something that's like an ER, they shouldn't be able to charge you more than a certain percentage over their average price. Just because it's an emergency room visit shouldn't be a significantly more additional cost. I also believe that hospitals ought to tell people how much money they make, what their executive compensation is, so you can start making informed decisions. Years ago, I talked to my mom and I asked her, my father was on some medicine, he was on Medicare, but they were paying for their own drugs. And I said, how much would it cost for you if the price went up at one of the drugstores you were at and you could find it cheaper? She said, I would move for $1. My mom finished high school. My dad had a 6th grade education. They weren't foolish. They could figure this stuff out. So it's wrong that our hospital industry doesn't tell us what things cost. It's not fair to patients. And if you go through these stories, so many of them, so many times they were turned over to a collection agency. In one of those cases, the hospital failed to file the right insurance and failed for a different insurance plan, so the patient was turned over to collection within a week. And this was a patient that's, from sound of it, wasn't making $15,000, $20,000 a year. And it ruined their credit. All these things, post your prices, tell people what things cost, let them make an informed decision about what services they want, and people will do it. And then the next thing, you've got to have penalties if people don't do the right thing. Right now in Florida, we have some legislation being proposed in our House and our Senate. We're in session. We started a couple weeks ago. And so they're talking about price transparency, which is good, but without the penalties. Now think about it. I'm sure not all of you stay within the speed limit. When you drive, you're never speeding. You're never going over the speed limit. But think how often you would go over the speed limit if there was just a sign and no penalty. How many would you say, oh, absolutely, I'm going to go to 55 miles an hour or whatever? Well, the same thing with anybody else. We have an instance right now in our state where we passed Medicaid reform back in 2011, and there was a requirement that our hospitals couldn't charge more than a certain amount to our insurance companies, because actually it's under the Medicaid program because we as taxpayers are paying for it. And we found hospitals not complying, but there's not a lot of pressure because there's no penalty in the bill. So my belief is everybody should know what everything costs. Everything should be posted online, and you've got to have penalties. And there ought to be a cap on above. The hospitals can set whatever prices they want, but you shouldn't be charged a significantly more in an emergency visit than a non-emergency visit. There's no reason it should be charged much more. It should be an insignificant amount more. So that's what we're trying to do. I think it's important. Back in 2009, I organized a group called Conservatives for Patients' Rights to try to get the proper healthcare reform done. It was basically let people buy the insurance they want. We need competition. In Florida, we have certificate of need laws. We ought to let, if somebody wants to open up a hospital and compete, let them open up a hospital and compete. We can regulate them on quality and reward people for taking care of themselves. Eat right, don't smoke, exercise, things like that. If you do, the cost of healthcare goes down, more people will be able to afford healthcare, and then all of us could afford the healthcare safety net we think everybody deserves. So with that, I'll be glad to answer any questions anybody has. Yes, sir.
Do you believe that incentives for positive performance, particularly hospitals, are more important or as important? Lou Gagliano, healthcare analyst. Do you believe that penalties versus incentives are an appropriate concept in terms of hospitals and quality outcomes measurement?
I think as in everything I do, I try to do the carrot rather than the stick. So I would my first reaction to everything is always let's put an incentive for people to do the right thing. But there are certain things you have to have penalties for, and so we can't take as an example with regard to quality. We ought to have incentives for quality, but we have some standards you have to live up to. So if you don't live up to those standards, we ought to have penalties. But if you're the best, then there ought to be incentives. Is the way I would sort of think about it. I think both they're used, and I think you can use them in different situations. Yes, sir.
Thank you. I appreciate your concerns about people maybe trying to understand prices. I was writing something about diabetes several years ago, trying to find out from my own doctor's lab how much an A1C test would cost, and it took like 3 weeks and a whole series of different questions and some near refusal just to give the information. So I think that's good. But I'm wondering your thoughts, and in Florida may be politically untenable, but your thoughts about what Maryland has, where they have all the hospitals get paid the same by all the payers, which obviously makes the reporting and information dissemination much simpler since there isn't a range of prices depending on who's your insurer.
I think we ought to have competition. I think we ought to let the free market work. I think the free market will work. You can see it now in we have urgent cares that are competing. They're talking about price. You have ERs competing by telling people how long the wait is. So I think you ought to let the free market work. Now, I think you have a choice on how if you're going to treat an industry like a utility, like our utility industry, we don't let anybody provide the utility services. So in that case, we have a utility service commission, public service commission, that reviews their compensation, their return on investment, their prices, and all those things. So I think you have a choice. If you're going to give people monopoly, then you've got to regulate it differently. So I'm very comfortable with the free market. I think in the free market, you're a smart consumer. You're just like my mom and dad. They figured it out. And if you'll look, LASIK surgery, sure, the people have sure figured that out. Yes. By the way, everybody ought to be in Florida. The weather is better. There's no snow. You don't stand on the street corner and get splashed with the melting snow. You might get a suntan. So.
Sure. My name is Kristen O'Ryan with the American Medical Association. So I know hospital charges are one part of the equation here, but I'm wondering what you're doing about the insurance companies, because I think the question a lot of patients really want to know is how much they're paying out of pocket. And if hospitals don't have that information, what are you doing to sort of make sure there's transparency in that market as well?
Sure. I believe there ought to be transparency in the entire market. You ought to constantly know what your copayment is, what your deductible is. Think about it. Our banks can tell us in a second if we have any money left in the bank and things like that. It ought to be So everything we can get done with regard to transparency in healthcare, I believe in. And so I would support anything we can do to give you, the consumer, more information. Yes, sir.
I'm trying to understand more about your bill. So hospitals would be required to post prices.
All the prices.
And each hospital negotiates a payment amount with an insurance company,
Right.
and they may, for any given service, have 10 different payment amounts. So how does that interact with an individual seeking a service who has a particular insurance plan?
Well, I think what you should know is, first off, if you have no insurance, you should know what it costs. So if you have no insurance, you should know exactly what it's going to cost. If you have insurance, you should know exactly what your copayment and what your deductible is. You shouldn't. But as an example, the patient that was told that referred to an out-of-network hospitalist, that's absolutely unfair to the patient, because because basically the hospital should have known that a hospitalist that works there would be in that patient's network or not, and you could refer a hospitalist that was in that network. So I think all those things are things that you should know as a consumer.
So you advocate for competition. Now, one hospital may get a better rate than from a plan than another hospital. So what do you recommend for a situation like
It's a
that?
free market. It's a free market. Let them compete, and what'll happen is a typical market works on price, quality, service, and so you'll get more information and you'll make an informed decision.
And what does the consumer make of all of this then? They're going to be changing plans, I guess, once they find out that they're going to pay less if they have Blue Cross Blue Shield than if they have Aetna.
I mean, they'll make a choice. I mean, I think that it's no different than thinking about whether the government should dictate to you what type of insurance you buy. I mean, one person might like chiropractic, another person might not. If it's mandated in the state, everybody's going to pay for it whether you use it or not. That's not fair. And so I think that we ought to give as much consumer choice as we can, and I'm very comfortable that consumers will make a good choice. Now, they're not going to make perfect choices, but none of us make perfect choices on what food we eat, what cars we buy, what houses we buy. But over time, we generally make better choices, and we'll have more information. And so the individual said they couldn't get any information from a lab. If the lab is constantly being asked for information, they'll have that information for us.
Just one last follow-up question. So there's some economists who say that in a world of perfect information like this, where hospitals have to share the negotiated rates they have with individual plans, that the hospitals that get the lowest rates will no longer have those available to them from the plan, and everyone's rates will rise.
It doesn't work in the grocery business. I mean, if you take other industries, people, like we have a variety of grocery stores in Florida, and so you choose between the type of grocery store you want, what types of food they have, what's the selection options. You should do the same thing with healthcare. There's no reason it should be any different. I mean, we all don't buy the least expensive cars.
Hi, this Leah Binder from the Leapfrog Group. You mentioned quality. I guess I want to ask if you can talk a little bit more about how you see quality transparency and safety transparency. It's obviously a big factor. It's not enough to know how much the price of something is. The next question you're always going to ask is, what do I get for my money? One thing I would want to point out with regard to Florida is you actually have a lot of hospitals that voluntarily provide a lot of information that through Leapfrog, but at the request of the Florida business community, provide a lot of information that other states do not have the same experience with. So it's to your credit. One thing that they do tell us, for example, that is troubling, is that Florida has the highest cesarean section rate of any state in the country. So just want to be sure that the quality equation is part of it, because costs won't go down on their own unless quality is also part of that free market equation.
I think you ought to have, I think you ought to disclose all your outcome measures. And because ultimately I think consumers, as they get more information, they'll shop based on price, based on quality, and based on service. When I was in the hospital business, a lot of people care about, you know, how fast the, how warm the food is and how fast you respond to the call button, sometimes more than the outcomes, because I think a lot of it is because they don't know. That's something they clearly can measure. We did about 120, when I was in the hospital business, we did 125,000 patients a quarter, I think it was. And we ranked all of our hospitals. And we did outcome measurement based on diagnosis on our bypass surgery as an example. So we could show our hospitals and our physicians and our nurses, everybody, you know, how well somebody else was doing. And so we all, because it helped all of us try to get better. And I think internally we shared that data. We were a big company, so maybe it was a little easier for us. But the truth is, consumers over time will want that data. I mean, I ask people all the time when they're picking, whether it's a hospital, a surgery center, or a doctor, what have you asked? And we all have to ask for more information. So everybody's all in?
I'll add a question. We're in politics, so there's always conspiracy theories afoot. Two polar extremes. One is if this price information gets disclosed, well, that'll just make it easier for the hospital industry to conspire to set basically the same common price. That it'll be easier to have an implicit cartel if all that information is out there. Now, there's a response to that. The other version of this is to say if this is all disclosed to the government, it'll make it easier for the government to regulate prices once they know what everything is, and therefore they'll end up setting it that way.
Well, on the second one, I believe in competition. I believe competition works. So I've got 3 more years in office. I don't think anybody has to worry about it in Florida over the next 3 years. On the first, I mean, apply that to every other industry. If you know what, you pay different amounts for groceries depending on where you buy things. And if you want convenience at a convenience store to buy something, you know you're probably going to pay more than if you shop at a warehouse type store. I mean, we all make those choices. And we ought to make those type of choices in healthcare. But without information, it's hard to make those choices. And without us making those choices, why would we want somebody else to make those choices for us? Why would we want an insurance company or somebody else, or our employer, or anybody to make those choices for us? We know what our needs are better than anybody else. I mean, think about it. You know, like I had in about now 20-some years ago, I had 3 kidney stones in 18 months. I can tell you exactly what to do to get rid of kidney, at least for me, how to get rid of kidney stones. So, and I know if I had one, I would know, I could tell you immediately when I got it. But everybody else's body is a little bit different. We all are gonna, we know how our foods impact us, our exercise impacts us, all these things. Yes, sir.
Interoperability of patient records has received a lot of attention, and it's not an easy subject to talk about. So what are you trying to do within the state of Florida to make patient records talk to each other? And are you using your influence, particularly the leverage of your state employee base, to suggest that the interoperability of those patient records ought to talk to each other regardless of where they're getting care done? I
think the feds, and with a lot of things in life, the federal government has taken charge of doing a lot of that. But here's my own personal belief, and I've always said this with regard to sharing patient records. Unless people are going to use it, when I got out of the business in 1997, all of our hospitals were connected. 343 hospitals were all connected. We could, if you came into one of our hospitals, all your records from the prior visit were in our facilities. If you're with a certain number of physicians affiliated with our hospitals, all that information was all there. That all sounds really good. It's irrelevant if people don't use it. So it's all great to have all these people share this, but if you don't use it, it doesn't matter. So I don't think it's, to me, if you look at it, Other industries have not had government mandated that you share information, and they figured out that it's positive to do it. So I personally would rely on the private sector to do it rather than government to dictate something, because I don't believe the way government will dictate things, it might be about 10 years old before it would, the proper way of doing it. It wouldn't be the right process. I'll rely on industry, and us as consumers will force it.
Miller with Capital Group. Two quick questions. One is on things like kidney stones or things where there's you're in pain, and how would you respond to the argument that you're not in a position then to make informed choices on price, and that there's a big chunk of aggregate health costs that may fall into those categories? So I'd love to hear your thinking on that. And then second, what do you make of Donald Trump's call for Medicare having price negotiation power over prescription drugs?
So on first off, most ER visits are not emergencies. Like I opened up and I had a urgent care company. We took care of probably somewhere between 70 and 80% of the patients that could go to an ER, and those were not emergency situations. So the truth is, it's a very small percentage. But on top of that, what you should do is you should say, in those settings, you cannot charge more than a significant number more than your average price. Your average, yeah, that's why I put in the bill. I didn't see what Donald Trump said.
Oh, he called for Medicare to be able to negotiate for prescription drug pricing. Typically, a more Bernie Sanders or Hillary Clinton position.
I would always rely on the consumer to make those choices, and I think the consumer will figure it out. I did when we were in the hospital business. What I did, if you were a physician at our hospital, you got to pick what drugs the patient would receive. What I did was I gave you information. I gave you, so when you decided what drug, on our system, we would tell you the effectiveness of that drug and the cost of that drug. So you still got to make any choices you want. The hospital took the risk of all that, but you at least were informed. I believe if you give people information, they'll make smart decisions. But no one makes perfect decisions. And we all have different ideas about what the right decision is, which I think is great. It's your money. Ultimately, if you think about it, whether it's tax dollars or whether it's insurance or your employers, which impacts your compensation there, I mean, it's ultimately your dollars. You ought to figure out how to spend those dollars better, and you will. Yes, sir.
How has your experience as a business executive informed how you've shaped the legislation that you're proposing?
I think everything you, everything you do, at least having been in the business, you know what information people can do. I mean, hospitals know what their prices are. I mean, so it's not like they can't figure this out. I mean, they negotiate rates with insurance companies, and they have charge masters, so they do know what things cost, what their charges are, and they know what their costs are. So I know that from a business standpoint, I know that this is all doable. But with regard to drafting legislation, you're also trying to figure out, you have a bill that you want to make sure it gets passed, and so you've got to bring everybody together to try to get something done. But the way I look at it, I represent the people that feel like they've been price gouged. And so if they've been price gouged, what can we do that is doable, that actually will do something for them? Given the opportunity to look at prices, make sure if it's a setting where they can't make an informed decision because it's an emergency, that the prices aren't above, never set the price for the hospital, but it shouldn't be above a certain number, what their average price for the same service is in a non-emergency case, and then make sure you have good penalties so people comply with the law. So who's going to Disney World? So you guys all come to Florida. The weather, I think it's going to be. I'm going to be in Naples tomorrow, and I think it'll be 80 degrees, and it'll be sunny. So Disney World, I think, is going to be about 75. All right. Thank you very much for the opportunity to be here. Have a great day. Bye-bye.
A second panel, so if you just allow the governor to leave while we do a little bit of a changing of the guard. Luncheon Forum this afternoon. Following the remarks of Governor Rick Scott, we have two excellent analysts of health policy in general and hospital-related transactions and pricing in particular to discuss this in a little further detail. Let me just give you a little theme setting. This is what is not normally said in the emergency room. Get me hospital price transparency stat. Maybe we'll get around to that later when they settle up on the bill. Just to give you a little sense of the baseline settings of transparency in U.S. healthcare, we do have some exposure to information, but necessarily in a more limited sense in the examination room, and it doesn't necessarily indicate what the price is going to be. But when we deal with these issues in the context of hospitals, and I will say parenthetically that we did invite representatives of the hospital sector also to make their case on this issue, and they've got a case to make in terms of it's not a one-sided proposition. The real question when we get into health policy and healthcare, though, is exactly just how transparent we want to be. But we'll see whether or not there's some further changes on that front. So with that as the brief opening, let me introduce our two speakers in a bit of an interactive presentation. David Hyman's going to lead off. Ben Ippolito will follow up, and then maybe a little bit of a crosstalk in between. David is a adjunct scholar at American Enterprise Institute, but his regular daytime job is at the University of Illinois, a paragon. Well, the state of Illinois is a paragon of transparency and ethical practices, but it's not David's fault that that happens to be ultimately his larger employer. But as long as the check's in the mail, I think is the motto these days in Illinois, and sometimes it does arrive. David is actually one of the
Small bills.
Unmarked, preferably, and without that explosion when they run away with them. He's done research and writing in just about every area of healthcare, and also taught at a number of universities, including at the University of Illinois currently. Those of you who know the longer history of David's involvement in health policy also remember his work as special counsel at the Federal Trade Commission, which certainly has some role in this, where he's the principal author and project leader for the first joint report ever, which is a real foundational document called Improving Healthcare, a Dose of Competition, looking at all the aspects of competition, not just antitrust, in the healthcare sphere back in 2004. And David publishes widely and cites himself widely and continues to do so. But it's all merited because it's really good work. So let's start off with David.
Thank you, Tom. And if I don't cite myself, no one else would. So, hopefully not quite. So I'm going to talk sort of more generally, framing the issues of price gouging and price transparency and non-transparency, and talk about sort of thinking systematically about how to diagnose the problem correctly, and then thinking more carefully than is often the case in the political sphere about what sorts of things we might want to do about it. So I'll sort of walk through the slides. First of all, the governor sketched out at a fairly high level of generality what his proposal is. It's actually 15 pages of proposed statutory text. And the basics, some of you probably can't see on the screen, so I'll go through it in more detail. Public disclosure of a couple of different things. Hospital gross charges, the average amount accepted across all payers, their charge master, all of those three broken out by either DRG or APG. Those are inpatient and outpatient groupings to try and give you a standard reference, as well as information about their charity care provision and posting of their Form 990s on their website. And they're supposed to disclose it. They're also supposed to turn the information over to a state agency. And then the sort of teeth in the proposal is an idea that charging more than a certain amount will be basically treated as prima facie unconscionability, and then you are required to refund the amounts. The state also has some additional regulatory authority, and it's basically greater than 115% of the average amount the hospital charges per DRG or APG, or greater than 100% of their usual and customary rate if it's not covered by their charge master. And there's a provision in there that references emergencies, but it also references all medically necessary care. And so my reading of it, which I'm subject to being persuaded that I'm misinterpreting it, is this actually applies to pretty much everything hospitals are going to do. Okay, it's not limited to emergencies, but encompasses hospitals more generally. So basic overview of my remarks. One of the things that you learn in medical school is if you don't diagnose the problem correctly, it's very difficult to get the right solution to it, and your solution may well make things worse. So I think it's important to start by understanding the problem you're facing and why it's taking place before trying to come up with a solution to it. Second point, price gouging and non-transparency are not the same thing. There's a tendency to sort of combine them, but they're distinct problems. If your problem is price gouging, the solution may vary depending upon what the cause of the particular situation you're facing is. Ditto for pricing non-transparency. It's important to diagnose before you treat. And then the last thing I'm going to talk about briefly, although the governor didn't highlight this, it's a very politically salient issue, is the problem worse in the for-profit hospital sector than the nonprofit hospital sector. So I'll talk a little bit about what we know about that as well. So in terms of sort of giving you the diagnosis problem, I like to use this example. Your car is going 90 miles per hour. Is it because you're driving it on a racetrack, in which case you intended to drive it that way and it's a permitted use? Is it because your accelerator is stuck or because your brakes have failed or as you're descending a mountain pass? In both of those instances, there's a problem with the car, but you want to fix the right problem, right? If your brakes have failed, solving a stuck accelerator, if it's not stuck, doesn't do much for the problem, and vice versa. Is it because you're pressing on the gas by mistake? That's an operator error. There's nothing wrong with the car. You don't need to fix the car. You need to worry about the operator. And then the last two, your teenage son is drag racing with his friends, or your teenage daughter is rushing to get home by her curfew of midnight. I have both daughters and sons, and I can neither confirm nor deny that these have taken place in my own family, but let me just suggest these don't map neatly onto the problems that I've listed before, and again, the kinds of things you'd want to do for each of them is going to vary, and that's a sort of general point, very straightforward. If you diagnose the problem incorrectly, you're not going to come up with a solution that'll fix the real problem, and you may make the real problem worse, long story short. So that's that point. So a couple of general observations. Price gouging isn't just about Florida. It's also not just about hospitals. It involves both, well, many aspects of the healthcare system, but specifically hospitals and doctors. Steve Brill's book has lots of examples of very high prices being charged to people. It seems to be much more common in two specific settings. First of all, billing the uninsured, being charged very high, sort of rack rate, charge master prices. A big part of what health insurance does is get you lower prices to begin with, separate and independent from whether the indemnity payout is sufficient for the purposes, but they're basically, it's like having AAA, you get a lower rate for the hotel. In the same way, having insurance allows them to negotiate lower prices. You also see it, as the governor highlighted, in out-of-network care issues. Part of structuring a network is the physicians and hospitals in that network agree to accept less money in exchange for tapping a larger and more reliable flow of patients, but that means people who are out of network haven't agreed to accept the same rates, and in some areas the sky's the limit to the amounts that they can and have charged. But it's also not just about hospitals and doctors, it's also about pharmaceuticals. Everybody know who this guy is, right? Martin Shkreli, who dramatically increased the price of, as it happens, a generic drug. And thinking about the price gouging problem, you may want to think quite differently about it if it's in the branded side of the market than the generic side of the market, and think about what the causes are. But it's also not limited to that. It's also the broader necessities of life. We've seen issues involving claims of price gouging, gas, heating oil, propane, water, ice, lumber, generators, housing, in the wake of natural disasters or the wake of run-ups in pricing of essentials of life. You see lots of concern and interest and efforts to enact price controls. This is actually a Los Angeles County Consumer and Business Affairs notice that is notifying people if you feel that you've been price gouged, which means that the price has gone up by more than 10% on something relative to what the price used to be, well, call us and we'll try and figure out whether there's a problem, and we'll sanction people if they're price gouging. So this is not unique to healthcare, it's not unique to Florida, it's not unique to hospitals. This is something that we see periodically in multiple sectors of the economy. It's also pricing non-transparency now. Switching from gouging to pricing non-transparency isn't just about Florida hospitals either. We've seen similar complaints involving hospitals and doctors. We also see similar complaints involving lawyers. I did go to law school, but I didn't find something better to do, so I stayed.
It happens to the best of us.
Yeah. I'll be sure to ask you to tell my mother that. There are large sectors of the legal services economy where it's very hard to figure out what something is going to cost. You can get fixed pricing for bankruptcy filings, for wills, and for uncontested divorce, but beyond that, it's pretty much far from clear what the prices are going to be. We also see it, interestingly, in governmental procurement contracts that are based on cost plus, at which point they're sort of open-ended. It's anybody's guess what they're going to end up costing. That's part of why those are controversial. Let me now sort of switch from that to, okay, well, what about the diagnosis? Why are prices high for some or all consumers? And this is a short and incomplete list of reasons why prices might be high. There can be a mismatch of supply and demand. The reason why gas prices go up in the wake of natural disasters is because you take out the capacity to either refine gas or to get it where you want it, and not surprisingly, there's a shortage relative to the actual demand. So Econ 101, a mismatch of supply and demand, prices are going to rise when supply is short or demand is high. You also should worry about monopoly or oligopoly problems. The antitrust agencies spend a lot of time worrying about whether prices are increased because of those circumstances. You can also have overt governmental policy to set prices higher than they might be in the absence of that policy. So restrictions on entry, the reason why people are keen to go to law school is because not everybody gets to practice law, and so we can charge more for the services that we're providing. The same goes for medicine, the same goes for lots of licensed occupations. IP protection, obviously, in pharmaceuticals is an important reason why prices are higher. Minimum standards also have this effect as well. They have benefits too, but they have this as a consequence. Also, price discrimination and price is no object reimbursement. If the government announces or your private insurer announces, no matter what the price is, we'll pay it, not surprisingly, the suppliers ratchet up the prices over time. And so the more open-ended the commitment to pay for whatever it is, including healthcare services, the more you're going to start to see resources flowing into that sector. So that's about high prices. Why might they be non-transparent? Well, you should think separately about what the demand side and the supply side factors are that explain that. And I think Ben's going to talk about that at least a little bit, and we can also cover that in the Q&A. But long story short, if people aren't spending their own money, and knowing the prices doesn't make a difference in how much they're going to have to pay, they're not going to be nearly as enthusiastic about knowing the prices, and the suppliers aren't going to be under much pressure to provide prices because doing it isn't going to steer business their way. And so you've got a sort of chicken and egg synergistic aspect in healthcare that's meant for lots of things. We don't have transparency of prices. So where do we see transparency, particularly in healthcare? Well, there's a bunch of things. Retail clinics post their prices. LASIK advertises prices. Plastic surgery, vasectomies. The Surgical Center of Oklahoma, which I think in the interest of time I will skip going through their website, but if you go to their website, you will find bundled all-in prices for about 40 different things. Major surgical procedures, all-in pricing, ex-ante, revealing those costs to you. And medical tourism, obviously, as well. And so I thought I'd show you a couple of examples, and of course, everybody wants to see plastic surgery, so here's an ad for Beverly Hills Plastic Surgery Center, which has broken out all-in prices for eyelid surgery, liposuction, tummy tucks, facelifts, rhinoplasties, and breast augmentation. And it's not just Beverly Hills. This is the Subway ad in New York City for breast augmentation, all in price $3,900. This, I will tell you, is the least racy of the 3 ads that they ran. And since I was using a governmental computer to download the image, I show you this one. If you want to see the other ones, which, by the way, were shown in the subway, you'll have to go look for them yourselves. So now let me switch to talking about, well, what has the law done about these kinds of problems in other areas? We've actually confronted price gouging in a very real way in other areas. So shipwrecks on the high seas create salvage problems. So if another ship shows up, they can basically demand anything to rescue the cargo, which will otherwise sink and be lost. And this is a very old body of law. The informational asymmetries are not particularly large, but the bargaining disparities are huge, right? You either sign the deal or you sink and go down with your ship. Not surprisingly, the law has a fairly systematic approach to that. First approach is anything you signed is subject to being thrown out by a court. They won't enforce the terms if they're essentially extortionate. Second is we have a sort of complex framework for issues that come to court to try and figure out what share of the amount that's saved the savor gets. If they don't succeed, they don't get anything. It's a no cure, no pay approach. This is a real well done paper by Josh Teitelbaum at Georgetown. It turns out the average, this is several hundred years of salvage awards by courts in the United States, they basically get 14% of whatever they manage to save. But there's also a private contract remedy. Lloyd's has a standard form salvage agreement that has largely supplanted the legal imposed result, and basically a group of experts decide how to handle it. So it isn't the case that markets are incapable of handling these kinds of situations, but you should at least think about what's special about this area that caused it to emerge and why we don't see something like this to deal with the kinds of problems we've talked about already, that is individuals who are uninsured or out of network. And that may give us some ideas about what to do about it. More on that later. Sort of wrapping up, non-transparency is not the same thing as price gouging. You can have price gouging with complete transparency, right? The people who were signing those salvage agreements knew perfectly well they were signing away 100% of what was rescued. Complete transparency, but still going to be gouging. Similarly, you can have non-transparency without price gouging. The two are not the same thing. How we think about them and what we're trying to fix should accordingly look different. Last point, non-transparency causes problems other than price gouging, right? Don't group them together, which is common. So let me then turn to the last subject, which is what about for-profits versus non-profits? This is a really nicely done study in Health Affairs of last year by Jerry Anderson and a co-author. And what they did is they looked at the ratio of charges to costs. Medicare collects information on this, and they basically ranked every hospital in the United States on the ratio of charges to costs. If your charges are high relative to your costs, you're starting out at a very high number for dealing with the people that you're sending bills to. And it's sort of buying 101, whoever puts a high number up sets the anchors the basic negotiation from there on, or a low number, and that's how they're doing it here. So they looked in detail at the top 50 hospitals. Basically, we're talking north of 8-to-1 charge to cost ratios for those 50 top hospitals. It turns out 49 of the 50 are for-profit hospitals. Most of them are in a system. They tend to be in urban areas, and they're much less likely to be teaching hospitals. But more to the point, there are 20 of them in Florida, and all of them are affiliated with 2 for-profit chains. So there's reason, at least, for having an index of suspicion that there is a problem here that we ought to be taking seriously and thinking about what to do about it. High charge to cost ratio doesn't mean that they're actually collecting that. Right? It's important to keep straight what the numbers do show you, but there is evidence of a Florida-specific problem. But it's also important to keep in mind nonprofits have misbehaved as well. Back in '03 and '04, there was an extensive amount of litigation involving nonprofit hospitals that were charging high amounts to people who didn't have insurance, and then using collection agents and the legal system, including having people arrested and effectively thrown into debtor's prison to try and motivate them to get paid. So this is the Hospital Debt Justice Project. You can go look at their website. It also made the front page of the Wall Street Journal when the Yale Law Clinic sued the Yale Hospital for misbehavior. I'm sure the faculty meetings, all university faculty meetings, were very calm after that. And there's a quote that ends the article: "The hospital thought it was safe squeezing poor families who didn't have the resources to fight back, but it's going to have to tango with a student-run legal clinic. Law students are tigers in training, bright, aggressive, and fearless. The hospital will learn that there is nothing more dangerous." This is actually Elizabeth Warren when she was a law professor at Harvard saying bad things about Yale. Okay? So let me stop there. And with where do we go from here? We can talk specifically about the provisions, but I just want to emphasize, really important you understand the problem before you come up with a solution. You should target the solution on the problem, and you ought to be aware and beware of unintended consequences. And with that, I'll turn it over to Ben, and we'll go on from here.
All right, well, let me introduce Ben as a segue to that. And let me just, as an opening to this, I want to apologize for not being able to have the technological capabilities to deal with a long-standing problem we've had here at AEI, which is, and this is happening in professional sports as well, it's hard to get a live crowd to come out to the arena. I mean, it's so much easier to sit in front of the large screen at home and watch it at a distance. And so I was thinking about some innovations which could possibly liven up and freshen our audience. Now, some of them were vetoed. The think tank president's race, that was not going to work, apparently. The Jumbotron with live replays in the midst of the broadcast. Apparently that wasn't going to work. But what I was going to pioneer today, and we'll take nominations and selections for future events, is walk-up music for each speaker. I won't tell you what the selections were for today, but at least they've been able to avoid that. So we're open to that for further suggestions. And live booing and cheering, I think, also would perhaps enhance a little bit of the live crowd. Home and away. It depends where we're holding it, of course. With maybe your name on the back, if you have your number, if you're a regular. With that as the stylistic aside, let me introduce Ben Ippolito, who's a research fellow in economic policy studies at AEI, where he studies healthcare policy economics, focusing on the behavior of healthcare providers, which I translate that as to what they do as opposed to what they say, which is a hard exercise to do. Ben is our newest addition to the health policy staff, because many of us have to find out data on occasion. We say, well, Ben, go dig it up for us. And explain it to us, well, that econometrics. So we appreciate that work, Ben. His recent research investigates how changes in financial incentives influence hospital care and how alternative compensation models influence the behavior of physicians and the way they treat patients. He has a working paper on the AEI site called Financial Incentives, Hospital Care, and Health Outcomes, Evidence from Fair Pricing Laws, which is very much on target for this area. Ben comes to us with a PhD and an MS in economics from the University of Wisconsin-Madison and a bachelor's in economics and math from Emory. Ben, go right ahead.
Well, thank you. I feel like I should have done some humming of my walk-up music, but wasn't prepared for that. But
we were
anyway.
going to give you actually from Hotel California in light of the recent passing of Glenn Fry's Johnny-come-lately new kid in town.
I don't know how much that would have got the crowd pumped up, but anyway. I'm going to do this from here just because I want to let David hop in as I go, but I've got some slides that are going to go up there. Right? Yeah, I got them. I got the computer here. So I want to start with what is a simple time trend, but I think is very salient and important for understanding this discussion. It's something that David has alluded to here, but this is more of the time series version of it. So what this shows is, this is data from essentially all U.S. acute care hospitals, and it shows two things, two prices. The solid line shows list prices. That's listed as charges here. And the dotted line actually shows revenue. So that's really what you should think of as actual transaction prices. And so the main point here is that 40 years ago, this concern about out-of-network or uninsured wasn't really that big of a deal in the sense that list prices were basically transaction prices. Right? That has obviously changed a lot over the last 40 years, especially in the last 15 years. So we're at a situation where this isn't just anecdotal evidence that the governor was bringing up, or David was talking about with the 50 worst, actors in this arena. This is a general phenomenon that list prices are much, much higher than a typical market transaction price. And so, especially if we want to think about issues related to price gouging, however we want to define that, if we're talking about situations where list prices are being involved, I think it's a genuine conversation that's worth having. So that's just a piece of, it's just an empirical fact I think that's useful to set the stage for this. So David laid this out already, but there's two basic ideas in the governor's proposal here to prevent price gouging. So the first is this idea of increasing price transparency. So that, I think we all are familiar with the arguments here. The idea is consumers know prices. They can sort of shift away from these high-priced hospitals to these lower-priced providers. The second part of the proposal is a much more targeted, much more active regulatory approach, which is explicitly limiting prices. I'm going to get to these two in order, but I think I'm going to spend a little bit less time on price transparency since David already talked a little bit more about that. So first, a word on price transparency more broadly, right? So this proposal is at least framed around this idea of price gouging, which we often think of as uninsured or out-of-network situations. Price transparency and quality information definitely has, it's useful for that kind of environment, but it's also useful in other environments too, especially when we think about how the insurance market's evolved over time, right? So 10 years ago, nobody had a high-deductible plan. So this is data from the Kaiser Family Foundation. 4%, I don't know if you can see this, but 4% of employer-sponsored health insurance plans qualified as high deductible. Now we're getting close to 30%. So to the extent that there's a movement towards price transparency, towards quality transparency, it is possible it's going to be useful far outside of these small, hopefully small pockets of price gouging concerns. Now, the question remains. There is this population that may be affected by these price transparency efforts. Does price transparency actually matter, though? And I think in the limit, the answer is obviously yes, right? Prices obviously matter at a certain point. And I think the one way that we're all used to prices mattering is when we think of in-network versus out-of-network. Like most of us who have insurance have some sort of network where care is much cheaper if we stay in network hospitals or with in-network physicians. So the vast majority of us tend to try and avoid going out-of-network if at all possible, right? Now, that's the best case, easiest scenario, right? It's a super stark difference. It's easy to find out who's in network typically versus who's out of network, and it's one unidimensional price that we can react to. When you start thinking about price transparency on a more inframarginal area, it is a little bit more difficult. But we do have some evidence from the literature on how this kind of pricing information, these pricing tools, affect consumer behavior. So most of what we know comes from the fact that we've seen a lot of employers switch the kind of health insurance plans they offer, right? So as employers shift towards high deductible plans, they often include price transparency tools as part of that. So there's this literature out there that studies what happens when firms introduce these things, how do consumers respond? And so the first, I guess, somewhat concerning result or hurdle that we face that's very clear is that most workers don't use price transparency tools, right? So you can cite a bunch of studies on this, but the paper I'm citing here studies a very large, well-known tech firm where you in theory, have very sophisticated consumers, and I think the number they had is that 7% of employees actually used the price transparency tool designed exactly for that insurance product for that employer. So in some sense, that's kind of a sobering statistic. It's not to say all hope is lost. There's a lot of reasons why people may not be using these things. It's possible they don't want this information. It's too hard. It's too costly to use. It's possible that people already have relationships with physicians, so they're not in the market to switch. It's possible that this is just a new technology that we have to get used to. There's all sorts of reasons this may be happening, but it's an important empirical fact to acknowledge that there is this hurdle to overcome. Having said that, there is at least some hope that you see if you can get consumers to actually interact with these things, then they do seem to make the decisions that we think they probably would make, right? They tend to go towards the lower cost providers. So I don't want that to be a totally negative comment, but it is important to remember that there is this hurdle to overcome. So I think the takeaway here is that the evidence is evolving. Most of what we know is based on firms, so it's going to be interesting to see what happens as states enact different things, different policies. And part of what's nice about what Florida's at least potentially doing here, is that we're going to see states impose a whole bunch of different types of policies where we can see what works, what doesn't work, maybe nothing works. Whatever the answer may be, it's going to be useful moving forward in this arena. Now, to the question that I think David raised, does this really address the price gouging issue? Well, it depends what's causing the price gouging. If it's an informational problem where we think all of a sudden having access to who's high cost, who's low cost, or who's high price, who's low price, if that's the hurdle, then sure, this could have an effect. If it's the emergency surgery situation, if it's the surprise anesthesiologist coming in out of network, maybe this isn't really, it's not a purely informational problem. So maybe that wouldn't address that aspect. Having said that, the second aspect of the governor's proposal does certainly address all situations. So the second part of this proposal is this limit on quote unquote unconscionable pricing, right? So the idea here is one way to stop price gouging is to just explicitly limit the price that anybody can pay in essentially any situation, right? So in the case of this proposal, you would cap payments from any patient at 15% above the average that a hospital is getting from Blue Cross, Aetna, United, Humana. So the question is, does this address the stated problem? Well, certainly yes. If you restrict every single price, then by definition, wherever there might be some price gouging, you've restricted the possibility to price gouge. You've also restricted every other price. And so every other non-gouging situation is now restricted as well. And so I think it's natural to ask the question, well, is there a reason that we want to restrict all those other prices? And is there a way maybe we can target this a little bit more effectively to try and focus on these price gouging situations that we're concerned about without maybe interfering with what seems to be, at least conditional on the healthcare market we have, reasonably competitive forces?
Can I stick in a word?
Yeah, go ahead.
So we agreed in advance that we would kibitz, so I'm not horning in without permission.
You would be more than welcome to do so if you want.
Oh, all right. Well, thank you. So I think the more explicit point to make is you should worry that this provision will discourage discounting to particular payers, because the discounts need to be taken account of in calculating the average commercial rate. And so if you offer a discount to some people, but you're capped at the top end at 115% of your average, you're going to be much less reluctant to offer the discount in the first place. Whereas if it's not subject to that provision, and you can think about ways of designing it that would prevent that, you're going to be more willing to discount, which in general we think is a good idea. And let me just point out by analogy concerns about the Medicaid best price provisions and the scope of transactions that were subject to that were basically flowing from exactly the same dynamic, and the sort of expected results happen when you expand the scope of the Medicaid best price provisions. You discourage people from offering lower prices throughout the market. Okay, so you don't really you chop off the top of the distribution, but you also lose the bottom of the distribution. You're suddenly doing all of your sales in a much narrower band, and that might not be what you're trying to actually accomplish.
Yeah, I think I'm going to touch on this a little bit later, but certainly when you think about PPOs, where you're restricting networks and funneling patients, it does seem like this kind of price would to some extent discourage that kind of agreement. So yeah. What I wanted to talk about is, okay, are there genuine situations where we can clearly identify at least a plausible market failure where we think this price gouging issue is particularly concerning? And then can we go from there and try and target the regulatory approach towards those situations? So I think there's two main candidates. The first is the story you hear on the news often, which is this surprise out-of-network bill, right? So you go to some hospital, you go to an in-network hospital, your attending physician is in-network, but somehow this anesthesiologist sneaks into the room right before your procedure and knocks you unconscious, but they happen to be out-of-network, right? So this is no longer the unconscionable pricing. This is literally unconscious pricing, right? So it seems like, I mean, that's a great business model for the anesthesiologist. It's not necessarily an ideal way to set up this pricing mechanism. So at the very least, if the market was working the way we
Don't forget the consulting specialist while you're also in a coma.
Yeah, right. So I mean, if we think about the way the market ought to be functioning in this case, consumers should be trying to get away from these hospitals where there are these rogue anesthesiologists sort of wandering the halls waiting for unsuspecting patients, right? But they're not somehow. There's some informational issue. There's something preventing that kind of behavior from sorting it out. So I think that's the first candidate. The second candidate, at least where we can have this discussion, I think, is the uninsured. So with the uninsured, this is something I've done some work on. it is incredibly difficult to find meaningful prices. So the uninsured, absent any regulation or charity on behalf of the hospital, are billed at list price. Even if states mandate that you have to post list prices, what that typically means is the hospital just dumps this 25,000 line item Excel file in billing lingo with some random dollar figures on the right side. That's not that useful to a typical consumer, even the most sophisticated one. You don't have a diagnosis, you don't know exactly how that's going to map to some treatments, let alone really specific ICD codes. So it's not clear that that's really that helpful. So prices are really not salient for those consumers. They're really variable, which is a problem when we think about two very similar hospitals could have totally different prices, right? So we can't even use simple heuristics to try and figure out, these are the kinds of hospitals that are high priced, these are the kinds of hospitals that are lower priced. And then finally, one of the things that's really important here is that hopefully serious healthcare is not a frequent a repeat purchase, right? So this isn't something where we can make a mistake the first time we get a bypass and then say, oh, the next 20 bypasses I get, I'm really going to hone in and re-optimize, and I'm really going to end up by that 15th bypass, I'm really going to nail it, right? So that's probably not going to happen. So I think there's a reasonable argument to be made that these markets are probably not at their peak efficiency, to put it lightly. So to really bring home this in a very, very circular way, I'm now going to cite myself to prove my point.
Been done before.
Yeah, I know,
Not
right?
Best.
Yeah. So luckily, a number of states have actually done this. So a number of states have instituted what are often called fair pricing laws, which explicitly limit how much hospitals can collect from uninsured patients. So the way this works is you basically write a law that says you can't collect list price anymore. You can only collect what is, however you want to define it, some sort of typical transaction price at your hospital. All right, so the question is, well, what happens to care, right? If we're really distorting this market, we might worry that all of a sudden we're going to see this huge drop in the quality of care that was being delivered to uninsured patients, and then maybe we've distorted this in a bad way. That's not what you see. Generally, you see hospitals make a reasonable effort to try and cut costs, which I think anybody would expect. They try and get you out the door a little bit quicker, especially if you're a less severe patient. They try and reduce relatively minor procedures if they can. But when you turn to a number of input or output measures, readmissions, mortality rates, complication rates, you really don't see any change. And so to the extent that's what we really care about as the outcome, it does seem like there was some room to improve efficiency in these situations. So I think there's a reasonable argument to be made for targeting this kind of regulatory approach to those two markets. Applying it more generally, I think, raises some questions. It's certainly a little bit less clear to me whether it would be as successful. We're now not in this world of totally opaque pricing where consumers aren't used to shopping for care. They're not used to figuring out, billing codes and whatnot. We now have Aetna on one side of the table, and we have, a major hospital on the other side. They come to some sort of agreement, and it's not clear, at least ex ante, what the market failure would be in these kind of situations. And as David very astutely brought up, this raises a lot of questions about, for instance, if we restrict maximum prices, one of the things we're going to do is essentially compress the variation in prices that a hospital can have. One of the outcomes of that, especially when we think of the way the cap works in this plan, is, well, as David brought up, so it raises this question of, is that a reasonable thing to do, number one? Is it reasonable to restrict this variation? If you think about the example of a wide network plan versus a PPO, it may not make a lot of sense for those two plans to have similar prices, right? It's a different insurance plan. So the PPO has this business model where we're going to restrict networks for our customers. What that means to the hospitals, we're going to funnel patients your way. And as part of that deal, we want to discount some of that's going to be passed on to the consumer. So it's a cheaper option, it's a narrower network. Fine. There are other consumers who don't want that, right? They want a wider network, and as such, it's going to be more expensive because you don't have the same bargaining power. Those two plans could have entirely different prices at the same hospital. That's not necessarily a bad thing. And when you extend it one step further, if you cap the prices the way this proposal would, all of a sudden you start distorting this issue that David brought up. All of a sudden, hospitals don't want to give this same discount to a PPO anymore. And it's not clear that that really is in the spirit, I think, of what this proposal is all about, because all of a sudden we're disincentivizing what is, at least to some extent, a cost containment mechanism that we have. So I want to wrap up just kind of bringing these together by saying, is there a way we can offer a a regulatory approach that's similar in spirit to what the governor's talked about, but do it in a more targeted way that doesn't have any of these concerns about distorting the otherwise competitive market? And I think the answer is yes, and we can learn from other states here. So New York and Pennsylvania have introduced, or at least are considering introducing, laws that explicitly target these surprise out-of-network bills, right? The idea is you offer protection, but only if the patient is at an in-network hospital with an in-network, I guess it would be attending physician, right? And so the same goes for one of these fair pricing laws, right? You only offer the protection to the uninsured patient who's at the hospital receiving necessary care. In both of these cases, I think there's a reasonable argument to be made that you've identified a plausible market failure and you've targeted the regulatory approach to address those problems specifically without having as much of this spillover effect. And so I think I'm going to end with that.
Okay.
And turn it over to our moderator.
All right. I'll just point out that, we have some current antitrust investigations as to think tank pricing for these events. It seems like we all charge the same amount, so it could be price fixing. On the other hand, we certainly don't gouge because we don't charge anything, but that could in fact be predatory pricing, in which case it could be double, triple indemnity.
But you compete on the lunch. So
service amenities is probably, and plus the incidental humor, I think, is where the real value added is. Let me, or subtract as the case may be. It's all chacun son
was
goût.
gonna say that.
That's right. Let me try a different policy variation on this, which I haven't seen approached in any state. If you just wanted to drive better pricing disclosure, we don't care what you charge. But you have a pretty strong incentive to be transparent about it within some parameters. What if you said that anyone pricing in this field who doesn't do that type of disclosure, it defaults to the Medicaid rate? That would be a pretty strong incentive to be above board with your prices.
Why not just shoot them?
Yeah, I mean, that'd be a de
Right?
facto.
Well, I like to kind of put a little strength on it. Then we'd have 100% compliance.
So there are a variety of ways in which you can structure increased transparency, right? And it's a question of how big a stick you want to use and how you want to structure the default. But a couple of observations. Once you've done that, the question is, well, what have we actually accomplished, right? So increased transparency on charge masters is may make people feel better, but it's sort of worthless in terms of actually informing consumers. So you need some level of bundling. It's important to recognize, patients don't walk into the hospital and say, I'd like to contract for a C-section with all the bells and whistles, right? I mean, and that at least is a defined unit.
And I'm feeling I'm going to have 2 unexpected complications.
Yeah, and I'm hoping to avoid an hospital-acquired infection. But if you give me one, throw that in, as
and do the tires
as the amenity package. Yeah. No, people don't walk in doing that. Part of the reason why they have agents who prescribe things for them is because of the profound informational asymmetries and the sort of optimistic bias people are going to have with these sorts of things. So that's one set of problems. So charge master disclosure, I suppose it may make us feel better, but I don't think you should expect any real results from compelled disclosure of charge masters. You're going to want some level of bundling. The second point, though, is you should be modest at best in your expectations about the consequences of any pricing transparency, just because leaving aside the specific examples that we've highlighted, there are lots of reasons where it doesn't matter to people, or they don't know what they should look for, or they don't have a meaningful choice, whether because it's traveling a long distance or because their insurance is only going to cover them at this one and not at this other one. I mean, there's lots of ways in which healthcare is a strange market, but it's not unique. There's an extensive body of literature that suggests that disclosure strategies don't have much effect. Okay, it's not specific to healthcare. It's not just about pricing. There are better and worse ways of doing disclosure. You can change the probabilities of having modest effects, but you need a variety of preconditions. Let me just, if I could, close with a specific example, right? So I have employment-based health insurance. Someone in the state decided that it was important to notify workers how much money was being spent on their behalf on their employment-based health insurance, okay? Which typically most people have no idea how much their insurance costs through their place of employment. And so they started adding something to every pay stub.
Well,
that
the
tells you-
ACA theoretically requires that.
Well, they
They've been
did it
slow to
before that.
implement it, and they've set a higher threshold.
They did it before that, okay? So that may make us feel better, but I will guarantee you it has no effect whatsoever on people's behavior, right? Most people don't look at their pay stubs to look at the detailed line item, and even if they did, their reaction is not going to be, boy, that's a lot for health insurance, I want to agitate for X, Y, or Z. Instead, at best, it will be, I'm glad my employer is paying this for me, rather than, gee, that's higher wages I could get if this number were lower. So I think, transparency, lots of people like transparency because it's a middle ground between not doing anything and doing aggressive top-down regulation, but I think you should be realistic about what the research shows about its actual effects.
We'll go to the audience, and do we have some microphones that are floating around? Let me make sure. Okay. You bring them on down. Just hold on a second. And as I usually say before the verbal op-ed, you can pretend to inflect at the end of your statement a question mark.
I will make a question mark at the end. The question is, I think if we go to the ultimate of what we're trying to achieve, which is better care for patients, then, and I'm reminded by a story that was in the Harvard Business Review talking about Intel and Intel arguing with their insurance carrier as to where their patients should go for surgery, because they were funneling them to a group of hospitals where the pricing was better, but the outcomes, in essence, were worse. And so, in essence, Intel argued that they ought to herd their patients for cardiac surgery to Virginia Mason system in the Northwest. So, if you think about transparency and you're looking at pricing but not outcomes, then you may be potentially making the wrong decision. And the only other point I would make is that, and I don't know how it's taken account for in the Florida system, but 70% of surgeries today are done in outpatient clinics, not in hospitals, which means that what you're left with in hospitals are really the long-term care issues that happen post-surgery, which is even more important, that the quality of care should be better in those institutions because of the complications that occur post-surgery. Question mark.
Or I can start if you want.
Yeah,
But-
I was just going to say, the one thing that underlies all of this is even when you start thinking about providing quality information, which in defense of the proposal, I can't remember if it's the proposal or what's been introduced, the Florida stuff does apply for inpatient and outpatient, and it does pair price transparency with some quality information. Having said that, trying to think about how to provide useful quality information, especially directly to a consumer. One thing that's important to note here is that putting this kind of information out there has other benefits, including other organizations can get this information and distill it in ways that might be useful. So that possibility is out there, but still, getting useful pricing or useful quality information is really difficult. Even thinking about somewhat aggregated stuff like, how do we fare in a general diagnosis category it's still unclear what a individual patient, an uninsured patient is going to do with that information. But, I don't know. It's certainly a challenge. You have to pair it. There's no reason to put the price if you're not going to put any quality, but how exactly to do that, I think, is a genuine question.
Yeah, I agree. I think the worry with doing price transparency but not quality is saliency and crowd out, right? People will focus on, oh, it's cheaper and assume quality is fixed, or at least not have a meaningful way of factoring one into the other. Certainly, it's very expensive. Having to do the readmit because you botched it the first time, even if you have a lower price per admission, that ends up being more expensive. And obviously, patients care a lot about quality for all of the obvious reasons. The second point, though, is if you're thinking about quality transparency, it's important to distinguish, and pricing transparency as well, it's important to distinguish supply and demand side effects, right? So if you disclose quality information, you might think, gee, patients will flock to the high quality provider, assuming they can make sense of the report cards that you've given, which, by the way, you can do that better or worse. I've done work on infection, public disclosure, and you can really botch disclosure, and I can tell you the states that have done it. But leaving that aside, the supply side effect, even if patients aren't responding, the people who work in hospitals and physicians don't want to be below average, right? And they're going to be motivated. Once it becomes publicly clear that they're not the top of their field, you can get real supply side effects even if there isn't much of a demand side consequence, because people are worried about it, and because they, as I tell students, no one goes to medical school to be in the bottom half of the class or the bottom half of the doctors, even though half of them will be, right? These are people who are passionate about delivering high quality care, and so part of the benefit of transparency at that point is to motivate them to do a better job.
The quality measures have generally been speaking to providers rather than to patients, because that's where they're developed. That's the insular community in which they evolve, and it tends to be, how can we do it better, or what are our preferred processes? Now, we're somewhat circling around the other end of that with more refined versions of patient experience, which begin to talk back to that and say, what does the patient care about within a zone? Although we've certainly got an over-proliferation of the wrong measures that tell you a lot of things that don't matter. I'd still come back, though, to the idea that if you start out with the idea that I'm choosing among several places, one costs a lot less, one costs a lot more, wouldn't you then want to know why the one that costs more is supposedly better? To drive the quality information once you were sensitized by what most likely at the patient level you'd care about on the out-of-pocket basis as to what it costs you. So I wouldn't dismiss that. We're a long distance away from having some type of evolved, sophisticated market. But if you never start doing it, no one's ever going to make the trial and error mistakes, stumbling around to say, oh, that first version was really bad. Just like information you used to get about other sophisticated products. But they do improve over time because there's a competition in providing better information which reaches the audience it's supposed to reach and people respond to. But let's take some other thoughts and questions on this issue.
Carnegie Mellon. I want to address the issue of market consolidation, because one of the reasons that you're having market consolidation on the insurance side and also on the hospital side is that they want pricing power. So even if you provide even a better mechanism for price transparency from a consumer perspective, one of the intended consequences of Obamacare has been market consolidation. And it is definitely driving up prices on the insurance side across the board. And it's even, what's even more surprising is, even in the Medicare managed care market, which you would think that it's fairly controlled, there's been significant price increases, especially in Mr. Scott's home state of Florida. So
I'll let the FTC guy take.
So look, market consolidation is a real problem. It was a problem prior to the enactment of PPACA. It's gotten worse. There are some areas where there's a single dominant player that can dictate price at will. See Boston. There are other markets as well. So that's a real problem. That's a distinct problem from the price gouging problem, but I agree with you that that's not a problem you're going to be able to do much about with price transparency or with price gouging provisions, okay? And so what's the solution to that? Well, antitrust enforcement, which the FTC and DOJ have been doing and have been more successful at of late than they had a 12-year sort of series of 0 for 7 with nonprofit and I think mostly nonprofit hospital merger cases. The other difficulty which is distinct from consolidation is doctors are remarkably enthusiastic about price fixing with one another. They don't seem to realize that it's illegal, and they've come up with
It's only a suggestion.
Yeah, usually when you think about cartels, you think about 4 to 5 people meeting in a smoke-filled room, preferably offshore. I mean, there are physician cartels with 1,200 people in them, and they're perfectly clear that the reason for entering into it is to get more money from the insurance companies because they're underpaying what they should be. And so there's, let's just say there's an absence of understanding of what the antitrust laws actually prohibit. And the agency's approach to this has been to take consent judgments, to sort of go and sin no more, which is not the way to create a different norm, right? If there are no sanctions, this is Governor Scott's point, if there are no sanctions for misbehaving, people misbehave.
When asked about how can you defend market consolidation, I like to resort to Ronald Reagan, and they used to say, how can you defend the larger deficit? He said it's big enough to defend itself. The antitrust regulators, hammer and nail is we're going to do merger enforcement. Well, that horse was out of the barn a long time ago. It's taken several laps around the track. And if you stop the next merger, you haven't changed what's already out on the field. And we are not going to unwind these through conventional antitrust tools.
So
now, and David knows this. The question is, what are the more creative ways to create better entry into this field? How do we get someone to bypass what's already on the terrain? Sometimes it's technological reinvention of the product. Other ways to get other players out there with a less dense regulatory framework to get in.
Right, so 3 quick points. The first is you can unwind a consummated merger, but it's difficult to say the least to do it. So Evanston, Highland Park, where the remedy was less than a stirring outcome, but it was at least a win, is one example of doing that. Unscrambling eggs is always challenging. But I agree with you, if the market's fully consolidated, unless you're prepared to sort of break up what are really integrated institutions, you then have to look for alternative mechanisms for market entry, right? So one is to encourage market entry by getting rid of your certificate of need laws and getting rid of the provision in PPACA that says basically no more specialty hospitals, right? It's hard to come up with a better example of incumbent protection than those two things. But the other thing, which I think will work better for some areas than for others, is to try and create broader geographic markets and medical tourism. Because if you can threaten credibly to go to a different market, suddenly consolidation in a small market is irrelevant, right? So if an airline controls O'Hare, but everybody can go to Midway and get lower prices, then controlling O'Hare doesn't ultimately give you much in the way of market power. So the insight that applies there, it seems to me, applies more broadly. There are lots of things where it won't work. It's not going to work for trauma care. It's not going to work for emergent problems. For chronic illness, where there's a defined, very expensive intervention, it's a no-brainer. We ought to be doing it.
Some other hands in the audience, Leah?
Leah Binder from Leapfrog again. I came in here knowing that purchasers in the private sector that we work with all the time are going to be very supportive, I would think, of this legislation. They're very supportive of price transparency. But having heard your comments, you've actually introduced a nuance to this legislation that I think would be very concerning to them, which is this issue that because of the restriction on, or potential restriction on the price relative to the average price, that they would be restricted on their discounting. And so that would be of great concern to purchasers, but also because they can't discount based on hospitals' performance. So that's becoming increasingly the trend among purchasers, to really look at those rates of complications or rates of outcomes and really offer major contractual provisions based on that, including discounts. So in some sense, this could actually move against the movement toward improving quality, because it actually creates a disincentive for those kinds of negotiations. But in general, my question is, where do you see legislation like this or other kinds of price transparency legislation? How do you see that impacting the private sector market?
Well, I mean, so I think it depends on it. In this kind of world where you start imposing price restrictions or price caps or whatever you want to call it, it's going to depend on the details of how exactly you do it. So in this case, I think there's a pretty clear incentive where you can see this PPO market unwinding, for instance. And that's just a function of how exactly this price cap is laid out. I think how it would evolve depending on all sorts of other specifications, you'd have to think through all the permutations of how exactly you'd set it up. But I think it's going to be a case-by-case basis. But the concern is more that there's a good probability that once you enter into these markets where we have prices that have otherwise been negotiated with full information, something like this is often bound to happen. And what exactly it is hard to say without knowing the exact legislation you're talking about.
Yeah, I agree with that. The point I would add, I mean, I hope I was sufficiently negative on price gouging in my general remarks, and if I'm not, let me reiterate it. Doing price gouging because of a supply-demand mismatch is profoundly stupid. Okay, it may make people feel better, but it's not going to make the situation better, and in fact, it'll probably make it worse. Doing price gouging legislation in response to some of the other things that I listed may or may not be a good idea, depending tremendously on the details of what you're trying to do and what's causing the high prices for some or all people, right? So you wouldn't want to use price gouging legislation to blow up the patent system, it seems to me. You might want to use it to deal with Martin Shkreli if you think you're not going to have collateral consequences more broadly, even though there are some other complications even in that one. But I think the big risk, and the reason why the commercial payers ought to look very closely at this kind of legislation, is because of the, I think, unintended but predictable consequences of casting the definitions too broadly, in the same way that the Medicaid best price strategy came out of perfectly understandable goals but had adverse consequences.
Joe?
Yeah, very interesting. As David said in his presentation, you have to try to understand what the problem is. And I think what we've mainly identified is that every conceivable actor in the health system is the problem, and there is no solution. So this is really gratifying to an economist.
Stop bringing us down, Joe.
But so one of the guilty parties that no one really mentioned is fee for service. Why is it that people overwhelmingly buy their insurance through their employers? It's not just because of the tax break. I think a lot of people don't really understand that, as David indicated. It's because they don't have to think too hard. You get a choice of one, and it looks like a good one because the HR director said so. That's what we say at AEI. So this gets really at not just consumers' difficulty with these admittedly complicated ideas, but also it has to do with risk bearing. Consumers don't want to bear certain kinds of risk. Providers don't want to bear certain kinds of risk. The solution, part of the solution, not the complete solution to everything, but part of the solution is to look at the business relationships. And of course, we have invented a business relationship that incorporates the risk in a maybe more sensible way. And of course, it's not fee for service. It's a capitated payment system where, with enough volume, the HMO, evens out the ebbs and flows of surprises in the hospital and so on. So I just wanted to raise, and I'm going to have a hard time making a question out of this, but I wanted to raise
Raise your voice.
I will raise my voice. I wanted to raise the point that part of this is the basic way we finance healthcare, as opposed to these random, let's give people more information. A lot of people don't want more information. I think that's the point.
Well, your question really is, to use a different vernacular term, who's your daddy? Someone's going to take care of you. It might be your employer, it might be your insurer, it might be your friendly doctor, but heaven forbid that I have to be responsible for this decision, because then I'd be taking care of my own life.
So look, I wrote an article a couple of years ago called 2 Cheers for Employment-Based Health Insurance. Employers get a horrific rap for their involvement in the health insurance market. There are obviously some historical reasons for that. But they do serve some useful functions, and if they were not doing it, somebody else would have to do it, and they could either be better or worse at it, and there's going to be variation in those things as well. Fee-for-service coupled with sort of open-ended third-party reimbursement, it seems to me, is a big part of the explanation. Fee-for-service in isolation, not necessarily so, right? I pay fee-for-service when I get my oil changed. I pay fee-for-service for all sorts of things because I'm paying out of pocket. The dynamics are obviously quite different, but that's, again, different than a sort of catastrophic outcome kind of problem, which is where you see a market for private insurance, or public insurance. The last point I'll make is with my co-author Charlie Silver, we're working on a book that explains how to fix all these problems. And so I'm looking forward to Tom organizing a book forum. The title of the book is Expensive by Design: Why the American Healthcare System Underperforms.
Citing yourself before it's even published.
Yes, yes. It's a whole new frontier that I'm working for here. The advantages of tenure.
I've heard of patent trolling, but this is the first time I've heard of a forum
Yeah.
troll. But that's not bad. That's not bad. Look, fee for service is basically saying I'm buying inputs. I'm not buying outputs. And therefore, you are paying for what people try to do or say they're doing, as opposed to what they achieve.
Yeah, I mean, it's an interesting question and has obviously a variety of answers as to why the healthcare system structures its pricing in the way that it does, right? And there's this wonderful video that is based on a Jonathan Rauch essay about if airline travel worked like healthcare. It was a New Republic essay that you can actually go on YouTube. There's a couple that reenacts the phone call with the person who's trying to book a flight from the East Coast to the West Coast. And you know, everything has to be done by fax. We don't keep any of their records from last time. Have you thought about who your cargo provider will be? We can only get you to the middle of the country, and then you're on your own for booking. And the dates we offer are not the same. I mean, it's this sort of wonderful summary. Why is it that in aviation and lots of other markets we see bundled products and bundled pricing, whereas in healthcare it's built around inputs? The book answers that.
Thought I may have seen another hand up there. I think we'll probably wrap up after that.
I just had a quick question about your thoughts on the effect of, I'll say, lower middle income. Those that might have too much money to qualify for Medicaid or other public insurance, might have a really high deductible plan, are very price conscious. My background's in nursing and health economics, so I've seen a lot of people, you know, right now, well, that's the closest hospital, that's the hospital I'm going to, being done. In the future, I say, okay, who's the cheapest? I'm not even looking at quality. And so all of a sudden you might have these hospitals that are terrible hospitals, but they're filled with patients because they're really cheap. So what are your thoughts on that?
Go ahead. That one's for you.
Oh, boy. I mean, one quick point before I turn it over to you for what I'm sure will be a brilliant answer, is that, I mean, at some point, you know, there is this question. Part of what you're raising is this idea of, should everything be sort of the same quality? And I mean, if you think about somebody who's really low income, and I mean, I know this can sound sort of crass, put the wrong way, but you know, a little bit lower quality for a lot less might be a reasonable trade-off. Now, how exactly to judge what those trade-offs are is a really tough thing. So I don't want to say that, you know, having any variation in quality is necessarily a bad thing, but your point is it's well taken. Especially, you can imagine sort of an unraveling aspect where, if it's all really low reimbursement patients going to the same bad hospital, it's hard to imagine that hospital then improving quality, therefore attracting more lower income. You know, so you can imagine that sort of spiraling dynamic, which would be a difficult thing to overcome.
So a couple quick thoughts. Mark Pauly has this wonderful phrase where he says, how come we don't see an insurer offering last year's medicine at last year's prices?
Right.
And you know, we can talk about why it is that the market tends to converge to nothing but the best and the latest and the fanciest, and we pay accordingly. But the hope of the people who designed, you know, the high deductible type strategy was that you would make consumers more cost conscious and they would make decisions based on that. That's obviously going to have a bigger impact on people who are closer to the poverty threshold than investment bankers and hedge fund billionaires, for whom dumping money into an HSA is actually a huge benefit. So that's a real distributional consequence. I think it's important to recognize once you blow through the deductible, price variation doesn't matter to people anymore, and that's part of the challenge, right? Who do we really think we're affecting by this, and how big of an impact are we going to have? I think the last point that I want to highlight, though, is people's decisions about where they go to get health care are often driven by location, location, location. Price is not, for obvious reasons, figured into it. It's where does my doctor admit, or where do people like me typically go? And so trying to disrupt those patient flows by transparency of price and making people bear the cost, I sort of have already indicated you may be waiting a while to see the kind of nirvana that you're hoping for.
All right, with that, if we were operating like hospitals, we'd be sending you a bill a little bit later on. It'd be rather complex. You'd find out there's some items that you didn't know you got that we're charging you for. But since you're all covered by being here in the audience, we'll just consider it uncompensated care otherwise and find some other wealthier donors to charge more out of them, or something like that. It all works out in the end, I suppose, in this best of all possible worlds. But we certainly had the best of all possible panels, and please thank them.
So